Thank you so much, Mr. Chairman, for this nice introduction. And I'm very delighted to be here in Suleimani Bak because part of my training was in this beautiful city. I will take you to a beautiful journey through the cases of thyrotoxicosis in pregnancy. This will be very interesting. I'm sure you will enjoy the presentation. Before that, I would love also to announce that here, what we did in Kurdistan for field of endocrinology as general, we are within weeks, we will deliver a book titled Historical Landmarks in Endocrinology and Diabetes. This will be released in UK and the rest of the world within a few weeks. In this book, the second chapter is talking about historical landmarks of thyroid gland. And I'm sure this is very interesting and you will enjoy reading this chapter. And maybe this chapter will be the next summit we will discuss how the evolution of thyroid practice took place in the history. Now, to start my presentation, I have three cases. The first case is a pregnant lady with hyperthyroidism. You were asked to see a 23-year-old lady. She is 11 weeks gestation, primigravid, with no goiter or eye signs, clinically euthyroid, and her TSH is 0.002, 3T4 is normal, 3T3 is normal. What's most likely diagnosis? As you know, this is straightforward subclinical hyperthyroidism, very common in pregnancy. This prevalence is 15% in the first trimester, 10% in second, and 5% in third trimester. Very common. Now, I would love to explain why there is subclinical hyperthyroidism in pregnancy. So, to explain this, you have to know the physiology of thyroid function test in pregnancy. What's going on? We know once the pregnancy started, the HCG surge will be high. This will cause for extra physiological demand for T4. This will cause suppression of the TSH and slight increase in the free T4. Everything will be back to normal once the first trimester finish. That's why subclinical hyperthyroidism is very common in first trimester. It is pure physiological event. Doesn't need anything. Just you may follow patient or reassure patient that it's quite normal, especially when there is no other signs of hyperthyroidism. So the fall in serum TSH in first trimester of normal pregnancy is a physiological response to high HCG. Peak at week 10 to 12. Don't depend on suppressed TSH alone without requiring 3T4 and 3T3 for diagnosis of hyperthyroidism in pregnancy, because you will be in pitfall of subclinical hyperthyroidism. So recommendation number one, never treat subclinical hyperthyroidism in pregnancy. This is a physiological event to supply the fetus with extra free T4 because the growing baby needs T4. The next case, which I will discuss, is a pregnant lady, again with hyperthyroidism. You were asked to see a 27-year-old lady. She is 10 weeks gestation with hyperemesis gravidarum. Now, clinically, she is euthyroid, but dehydrated, with no goiter or eye signs. TSH is suppressed. Free T4 is slightly increased. Free T3 is quite normal. TRAP is negative. So what's most likely diagnosis in this case? The most likely diagnosis is gestational transient thyrotoxicosis. Again, a physiological response to hyperemesis gravidarum. Why hyperemesis happen? Because of high HCG surge. It's the same mechanism of subclinical hyperthyroidism. To explain this more, this is the most important slide in this presentation, because the whole story of hyperthyroidism in pregnancy is to look for cases of Graves' disease, because those should be treated because of complications. But you have to differentiate Graves from others. So this slide will give you the clue. Why it's important, Graves require treatment, transient doesn't require treatment, it's self-limiting disease. Symptoms predate pregnancy in Graves. Hyperemesis gravidarum is present in 60% of cases of transient because HCG explained the both pathophysiology. And positive family history in Graves, negative in gestational transient, and goiter ophthalmopathy may present in Graves, but they are negative in gestational transient, and raised free T3, but normal free T3 in 85% of cases of transient gestational thyrotoxicosis. So this is one way to differentiate. Very simple. 3T3, if it's normal, it suggests this is gestational transient and doesn't require anything. TRAP is positive in gravis, it is negative in gestational transient. So possibly one of the simple trick, normal 3T3 is present in 85% of gestational transient. Only you will see mild elevation in 3T4 and TRAP is negative. So the other name of gestational transient is also called transient hyperthyroidism of hyperemesis gravidarum. So if you saw a patient, she is hyperemesis and she presents with this scenario, please think about this one and do not treat her with antithyroid drugs because this will harm the baby. That's why you don't need to treat hyperthyroidism. In this case, you only treat hyperemesis and you wait and see the approach. Now also, I would love to explain that thyrotoxicosis in pregnancy, you have to know there are some things which cross placenta and others don't. For example, T4 cross placenta, TSH or TRAP cross placenta, which may stimulate the thyroid, causing hyperthyroidism of fetus, or may block thyroid, causing intrauterine myxedemia or hypothyroidism of fetus, even if the mother is euthyroid. Keep this in mind, please, especially if the cross 3 folds of upper limit of normal range. And also remember that antithyroid drugs, they cross placenta and they may harm the fetus. Please keep this in mind. Now, top tips to remember, thyroid autoantibodies trap cross placenta. It affects fetal thyroid after week 12. Why? Because there is no fetal thyroid activity before the week 10 to 12. Usually it starts after this period. And fetus can develop intrauterine myxedemia, which is hypothyroidism, or hyperthyroidism, even if the mother is euthyroid due to TRAP. So why we do worry about hyperthyroidism? Why we want to treat hyperthyroidism? It's all because of gravis. Gravis disease cause complications in pregnancy. What are those? Maternal risk, congestive heart failure, thyroid storm, pregnancy loss rate is 45% without treatment. And also remember, there is residual risk with good control, like placenta abruption and cesarean section. And also, don't forget the fetus point of view too. So recommendation number 2, assess carefully for gravis disease. As it accounts for 85% of cases of hyperthyroidism in pregnancy, and we are looking for those to treat those to prevent complications. And maybe one of the good points is gravis orbitopathy, which may suggest that this is gravis disease. The goal of treatment, so I reached the treatment, Mr. Chairman. The goal of treatment is what? Is to induce persistent but mild hyperthyroidism. That's very important. We want persistent mild hyperthyroidism. We don't want absolute euthyroidism because we do worry that we will induce hypothyroidism of fetus. And I will come to explain why this. Because in attempt to prevent fetal hypothyroidism, you have to keep either at upper T4, at upper limit of normal range. Even mild persistent hyperthyroidism is not a big deal, please. You don't need to reach absolute euthyroidism in this case. So you have to make a balance between mother's hyperthyroidism and fetal hypothyroidism. Please remember that the fetus thyroid is more sensitive to the action of antithyroid drugs than the mother, because the mother is diseased one, but the fetus may be healthy one. So remember that may cross placenta and may cause block. That's why you have to be very gentle in this case. Balance is not something that you will find, it's something that you have to create it. And that's why please don't forget the fetus while you are treating the mother. Also, you have to remember that the side effects of the antithyroid drugs, I'm sure Dr. Taha is more aware about those, that the carbimazole can induce birth defects in different way. It can cause aplasia cutis, penile atresia, omphalocele, and I'm sure you are aware also it can cause esophageal atresia, the omphalomesenteric duct defects, and all those complications are more common in methimazole, carbimazole exposed children than the others. So don't forget that those complications also, they are dose dependent. As you are more aggressive, it means you will have more of those complications. So please also don't forget the side effects of those antithyroid, because all of them, they cross placenta. And the propylthiouracil also can induce preauricular cyst and hydronephrosis. And also, you have to remember that carbi and propylthiouracil associated with the urinary system malformations. Propylthiouracil cause malformation in the face and neck region more than the carbimazole. But none of them is absolutely benign. And also remember that this is very, very interesting article from JCEM. You know, this is the very important journal in the field of endocrinology. It looks to the impact of exposure to carbimazole and propylthiouracil. Once you expose the fetus to those, the birth defect hazard ratio will shift to the right whenever you expose them. It's only neutral when there is no exposure. But you can see that the carbimazole is more dangerous slightly than the propylthiouracil, but none of them is absolutely benign. So all of them, they increase odds ratio of birth defects. And the only way, if no exposure, it will be neutral. So propylthiouracil causes less birth defects slightly in comparison to carbimazole exposure. It's imperative to treat overt hyperthyroidism in pregnant women, but the use of anti-thyroid drugs, and that's a very clear message and important, in early pregnancy should be limited to the lowest possible dose, which control mother and prevent complication on the fetal side. And that's why it's important. But also remember that the ATA or the FDA, there was warning about the propylthiouracil, and the practice in ATA guideline is like this one. You have to use propylthiouracil in the first trimester. We tend to shift patient after the end of the first trimester to the carbimazole for the rest of pregnancy. Why this? Because we know propylthiouracil associated with a severe liver injury, especially if used in second trimester. So the practice is propylthiouracil, only we use it for first trimester, and then we return back to the carbi or methimazole, as you all are aware of this. But also, it may be imperative to shift women planning for pregnancy from carbimazole to propylthiouracil just before the start of pregnancy. When they want family, you can't do this shifting because usually when they visit you, they are a bit late. So the only indication for propylthiouracil is either intolerance to carbimazole or its first trimester of the pregnancy. By this, I finish the presentation, and I would love to finish the presentation by a quote from Gandhi. You know, this anti-colonial nationalist has very nice quote which fit this subject. In a gentle way, you can shake the world. And actually, he only by fasting, and his strike, he shake the world. And also we can say, which apply to this presentation, that to treat hyperthyroidism in pregnancy, you should be very gentle. Use the lowest possible dose of anti-thyroid drugs. That's the clear message. And thank you very much for your attention.
Thank you very much, Dr. Bayar. As usual, your presentation is fantastic.